Hello, hello.
Hello.
Can you hear me properly?
Yeah, doctor. You can check your PPTs.
Now is it visible?
Doctor, move to next slide. हाँ ठीक है doctor. You can stop share now. We'll wait till others join.
Okay.
Dr. Sanjay, can we start, please? Dr. there?
Hello. Can we start? Hello. Hello.
Hello, we can hear, yes.
Yes, madam. Yogesh.
Dr. Sanjay, you
Yes, ma'am.
there?
Can we start?
Can we start?
Yes, you can start. People will join because it is already
Hello.
overlapping with the one more
Dr.
meet, which is
Sanjay?
already going on. Since we had a national neonatology conference over here, the one meeting of national neonatology conference is already there. Hello.
So should we start?
Yes, Birada
Shweta
sir.
is,
You can start.
yeah, I think Shweta is not responding well. That is
Ah,
okay. Yeah. So the topic for discussion is role of probiotics in dysbiosis.
Please start.
yes, ma'am.
Start. I think there
Your
is
sound is
some
not clear, madam.
problem with the Sanjay. He's the president. He can.
Hello. Can you hear me? Am I audible?
Yes, sir, you are audible.
Yeah. Okay. Good evening, sir. Good evening. Good evening,
Good
all.
evening, sir.
Good evening, sir. Today I'm the president, Dr. Sanjay Pakmude, President AOP Nagpur, and we have been allotted this topic of role of probiotics in dysbiosis and how to choose an ideal probiotic. Now we know nowadays lot much is talked on the probiotics. We know everything can be explained with the probiotic. So this is a wonderful topic where we want to hear from Dr. Birada sir the word of wisdom from him how the probiotics help in dysbiosis. So on behalf of Nagpur AOP, I request Dr. Biradar sir to start his session of role of probiotics in dysbiosis.
Thank you, Dr. Sanjay. I think the probiotics or this topic has been discussed in every meeting and every national conferences, every specialty conferences it is discussed. So what this IAP module has made uh, possible that what is the literature, and through this PowerPoint presentation, I will try to demystify the myth which we will be having. So trend in publication in 40 years from 80s to 20s, there were only 3,400 publication on probiotics, and from 2015 to 2013, in last 8 years, there are almost 3,000 publications. So that much interest has been generated through, all over the world about what these tiny organisms can change the future of the diseases or the change the natural history of the certain disease. So is it a hip or hype? So my understanding, seeking the truth, I should be balanced between the hype and the truth. Hey, so we will go through the evidence and literature. So what determines this hype or hype? Is the disease in question, that what disease we are treating with the probiotic, like infection, allergy. What is the probiotic we are using? Is it a single, multiple, dose, strain? Everything matters. And the credibility of the scientific data, which journal it is published, which study it is it meta-analysis, is it a randomized control trial? And then the angle of analysis of the researcher, like a pediatrician or us, that how we are going to look after the particular study. So like this glass is half is full. Somebody say half is full and somebody say half is empty. Both are correct. So with the evidence which is there, we will go through the what it is actually. So why we are confused? Because vested interest by the authors. It is pharma funded trials. There is lack of own data from India or the Asian country. We heavily dependent on the Western data. And what is the role of probiotic, which we discuss? Infection, functional disorders, allergy or immunity related disorders, or a genetic disorders like inflammatory bowel disease or some other diseases. So all these are interlinked, and this whole will be through the gut. So gut decides about everything, and that is how we think that changing the gut microflora, we will able to reduce the burden of infection or allergic disease, or we can able to treat them. So where we use probiotic, one is the therapeutic purpose, and the other is prophylactic purpose. And we see the efficacy and safety before using any probiotic. So let's see first condition, necrotizing enterocolitis. There is a robust data in the NAC. So the incidence of NAC, we all know as a pediatrician, it is almost 1/4 of the preterm babies will get NAC. And uh, among them, the late onset sepsis, which occurs in very low birth weight babies, and that leads to a surgery in almost 50% of the cases for NAC, and mortality is 20 to 30%. So why this happened? Because of the immature intestinal barrier, gut immunity is immature, the gut microbiota has not been established, there is stasis because of n number of things which happens to this preterm, and then there is a translocation from the gut to the systemic, and that is how they develop the sepsis. So they have high enterobacteriaceae and very less lactobacillus or bifidobacter, which are the good bacteria which we should have. So can we prevent necrotizing enterocolitis or late onset sepsis, or can we treat and prevent this poor outcome by using probiotic in these children? So this is a case of 2-day-old female, 34-weeker, Apgar score of 8 at 1 minute, 9 at 5 minutes, had a very acidotic pH of 7.17, received vitamin K, uncomplicated pregnancy, and started having the bleeding PR. So what factors we think should be the cause of concern in the preterm? Is it the maternal health? Yes, it definitely decides about preterm. Delivery related factors, is it a vaginal delivery or is it a cesarean section delivery? Is the child on breastfeeding or is the child on formula feeding? And what are the possible GI issues in this infant? So the most prominently, we always consider bleeding PR in preterm as a possible GI issue. So what's the confusion here about probiotic? Because every year Cochrane and meta-analysis keep on changing. And why they keep on changing? Because of the availability of the interventional data which is there. They are not clear about what time we should be starting probiotic, which strain we should be starting, what dose we will be giving, how much duration we should be giving, at what gestational age they wanted to give. So we say ki preterm less than 34 weeks. So they wanted to give at 30 weeks or 32 weeks or 31 weeks. What is the cutoff birth weight? Is it 1.5 kg, less than 1.5 kg? Is it the 1.2 kg or 1 kg or 900 grammer? So, and there are multiple interventions in this. Somebody is on the CPAP, somebody is ventilated, somebody will be on the formula feed, somebody will be on the breast milk, somebody on human milk banking. So there is lot of heterogeneity in the data, and that is why it is not clear. But we will able to make you clear through some of the recent data. So this is one of the meta-analysis from the on the probiotics in preterm, and there were 51 randomized controlled trials and 11,200 preterm infant. And what the data has shown that the mortality related risk has gone down with the help of the combination probiotic like bifidum with acidophilus, bifidum infantis longum acidophilus combination. So with this combination, the risk ratio has been just 0.16, 0.26, 0.09. So it is quite good. So the risk of mortality has gone down. And NAC grade 2 or 3. So with the multiple strains like Lactobacillus bifidobacter lactis, Lactobacillus reuteri, Lactobacillus rhamnosus GG, or Bifidum infantum longum acidophilus combination has relatively reduced the risk of NAC grade 2 and 3 in these preterm children. Late onset sepsis, the relative risk again will be reduced. But the data is very clear about that the time duration which is required for the giving, the need for the giving this medicine till the full enteral feeding is established, that data is not clear. It is still in the infancy. So do we all agree that probiotic is safe in preterm? It is doubtful. So what probiotic should have when we say it is safe? It should not produce delactate. It should not contain antibiotic resistant capability. And the certificate of analysis should be there, like purity, viability should be there in that particular strain. And we have to take informed consent from the parents. And there is a risk of fungemia. So the fungal strains are not used in the preterms. That is very clear. And the evidence for that is low. So what ISPAGAN, that is European Society of Pediatric Gastroenterology, Hepatology and Nutrition, says in 2022, that Lactobacillus rhamnosus GG or combination of Bacillus bifidobacter infantis, lactis and thermophilus reduces the NAC stage 2 or 3, and the recommendation is yes, though the low certainty of evidence is there, but data is clear that if you use 1:10 raised to power 9 colony forming unit of the Lactobacillus rhamnosus or a 3 to 3.5 into 10 raised to 8 colony forming unit of the combination of the probiotic, then it definitely reduces the NAC stage. The data is not clear that what the duration is. Is it only 4 to 6 weeks or until discharge? And some of the studies recently which have came up with that you give it for 6 months after the birth of these preterms. And that data is also robustly showing that there is a definitely reduced risk of infection and allergies. But it is very clear in the ISPAGAN statement that Lactobacillus reuteri, no recommendation. Combination of bifidum with acidophilum, no recommendation because they are partially delactate producing strain. So this should not be used in the preterm in the NIC. Brevi and Saccharomyces boulardii, the data is against, so they should not be used. Saccharomyces boulardii is again a fungal strain, so should be avoided in the preterm. So how much benefit we are getting with the use of probiotic? So prevention of NAC, a 3.5% reduction on the overall percentage. A gut-associated sepsis 15% reduction and a mortality 5% reduction. That is huge. A 5% reduction in the mortality. That means 1 in 20 is going to be survived with the use of probiotic in the preterm. And that is a good number. So to prevent one late onset sepsis, we needed to treat 44 preterms, and that is what is cost effectiveness is not better if we start using it for every preterm. Again, the American Gastroenterology Association says the same thing. We should be using the combination of lactobacillus and bifidobacter. Different compositions they have already said, and this recommendation is conditional with moderate to high quality evidence. But there are still gaps in the research imperatives because head-to-head comparison between the two groups of the probiotic is not there. The dose time of initiation and duration is still not clear. We need to have a more data in very low birth weight preterms like less than 1 kg. And we should be having the data on different milk and what is happening to them. The administration at present, powder is more stable. So we wanted to use powder form of the probiotic, not the liquid. And we are not sure about long-term safety, about the immunity, endocrine problems or metabolic syndromes in the future. And we are particularly in the north, there is a different has the different demography, ethnicity, and cultural practices. So we still need a robust data in this. Am I audible? No? So the second disease is acute infectious diarrhea. So there are proponents and opponents of Eastern Europe is proponent of probiotic use, and the North America and West Europe is opposite views on the use of probiotic. And we are always confused because we don't have our own data, and there is a heterogeneity in the Asia, Latin America, and Africa. And why it is so? Because of the income disparities. Severity of diarrhea is different in Western countries and the Asian countries. Immunization status is different there and here. And the etiology is not yet viral, bacterial, or unidentified, is different in different parts of the country. And the intervention factors like what days we should be intervening. Is it on the first day, second day, within 72 hours, after 48 hours? Is it the single strain should be used? What is the dose of the strain should be used? What is the duration and what kind of trial it is there? And that is why there is so much heterogeneity in the study. So this is a plain case of 3-year-old child having a gastroenteritis, 5 to 6 episodes with nausea, no dehydration, and she was okay, all right. So in this, should we use? So what is the appropriate course? Should we give probiotic, or should we do some diagnostic tests like viral culture, viral etiology, biofire, bacterial, parasitic? Should we change the probiotic, what is being used by the other? And what should be and we always know the supportive care of hydration and the dietary adjustment in patients of acute infectious diarrhea. So for us, it is very important that what will the effect of probiotic? Is there effect on duration? Is there effect on the volume of the stool going down? Are we going to reduce the hospitalization days by using the probiotic? And these are the 3 questions, primary questions for as a clinician and for a parents also. And we always use modified basic risk scale to decide. So anything more than 9, we are worried about because it is a severe form of diarrhea. So we wanted to reduce from basic risk scale more than 9 to less than 9 so that the complications of diarrhea are less. So what the ISPAGAN says about use of probiotic in acute infectious diarrhea. So Lactobacillus GG, Rhamnosus GG, Saccharomyces boulardii, there is a very low or low quality of evidence, and recommendation is weak in favor of use of probiotic. The same with the Lactobacillus reuteri and Bacillus clausii. Okay, but it is against the combination of Lactobacillus helmictus, Rhamnosus, or any other combinations like Rhamnosus with reuteri. So the clear statement, though there is a weak recommendation and very low quality of evidence, still the single strain is useful in acute infectious diarrhea. So how much usefulness it is there? So different strain, and it is the meta-analysis which is done. So Lactobacillus rhamnosus GG and Saccharomyces boulardii will reduce the duration of diarrhea by 24 to 28 hours. Okay. Bacillus clausii reduces by 8 hours. The Rooteri and Acidophilus with bifidum reduced by 24 to 28 hours. And Lactobacillus acidophilus just by 2 hours. So it is a clear cut that Lactobacillus rhamnosus GG and Saccharomyces boulardii, Lactobacillus reuteri are clearly showing a decreased duration by almost a day, which is possibly a significant for a parent. But it is again a conditional accommodation by the American Gastroenterology Association because the quality of evidence is not great. There are certain landmark studies. There was one study from 2009 in the South African countries. Then there is this study published in 2021 about the lactobacillus GG, and which is a randomized controlled trial. And mind you, this is more than 800 children, but it is done in the Western country. So what they have shown that the duration of the diarrhea, the episodes, the vomiting episode, and chronicity or the persistence has not been a different in both the groups, in the placebo group and in the lactobacillus GG received group. And this is again a study in 2018 published in NAGPUR, which showed the combination of Helvictus with rhamnosus. There is not clear-cut efficacy of using the probiotic in the acute infectious diarrhea. So now it is clear that there is no clear-cut benefit. Both the studies got a severe criticism, and that is why people say that criticism is that both the studies had a milder severity of diarrhea. In Asian countries, we have a moderate to severe diarrhea. North America doesn't represent the world. There, the children are majorly immunized with the rotavirus, and the probiotic was given after 48 hours of diarrhea and used in the liquid form. So there are criticism to both the trials. So what European perspective about this probiotic? So there is no reduction in stool volume, but reduction in duration of diarrhea by almost 1 day. The dose has to be 10 raised to power 10. So it has to be billion colony forming unit of that lactobacillus GG, and reduction in hospitalization by more than 1 day. Asian perspective, again the same, reduction in duration by 24 hours, and it is more effective if it is introduced less than 72 hours after onset of the diarrhea, and better in the rotaviral diarrhea, which we commonly see in our Asian countries. The same thing about the Saccharomyces boulardii. It reduces duration by 1 day, hospitalization by 0.8 day. So almost similar kind of efficacy for the both. Bacillus clausii, reduction of duration of diarrhea by 9 hours and hospitalization by less than a day. So lesser than what it is there with the lactobacillus rhamnosus GG and Saccharomyces boulardii, but it is better. And there are 2 studies by Lahiri group, and they shown that it is useful in the Asian countries. Lactobacillus reuteri, they say that it is reduction in the diarrhea, but there are no Indian studies for this. So summary of Indian studies: Lactobacillus rhamnosus, there are 4 studies; Saccharomyces boulardii, there are 2 studies; Bacillus clausii, there are 2 studies, and it is a mixed result. Majority say there are certain benefits, and that benefit we know that it is reduction of diarrhea by 1 day and reduction in the hospitalization by 1 day. Combination doesn't have any role in patients of acute infectious diarrhea. What about other diarrheas like antibiotic associated diarrhea, Clostridium difficile diarrhea, nosocomial diarrhea, inflammatory bowel disease? I'm sure that many of the pediatricians have started seeing some of these conditions, particularly antibiotic associated diarrhea and IBD. And we as a pediatric gastroenterologist see a lot of Clostridium difficile diarrhea presenting with a persistent or a recurrent diarrhea in the infantile age group. So what is your opinion? Do you agree that they reduce the severity or in the incidence of this? So maybe half of them agree or half of them disagree, but we will go through the evidence what it shows. The American Gastroenterology of Association says the combination therapy, combination of the probiotics are useful in prevention of C. difficile infection. It is not the treatment part of it, but the prevention of C. difficile. So any antibiotic we use, we should use either a single strain or a combination for prevention of the C. difficile. But when to give, whom to give, and how long to give, that question needs to be answered. So it has to be started preferably on the first day of the antibiotic. I think any child less than 2 years, I preferably want to give them the probiotic along with the antibiotic to prevent this C. difficile infection. And how long to give is till your antibiotic is there, minimum 5 days, or your antibiotic is there for 7 to 10 days. Till that time, you should be giving. Mind you, you should avoid giving in immunocompromised state. Is there any role of probiotic in treatment of C. difficile infection? No. No role in ulcerative colitis, no role in Crohn's, no role in persistent diarrhea. But in pouchitis, where ulcerative colitis child underwent a colectomy and had a pouch, and then this pouch got inflamed, that is what we call as an inflammatory pouch, which is pouchitis. There is a role of high dose of VSL3, which is a combination of multiple strains of the probiotic, and which has clearly shown the benefit, but the dose there of VSL3 is quite high, what we are getting in Indian market, which has a very low dose. What is the ISPAGAN guidelines or the statement about nosocomial diarrhea? So probiotics for preventing nosocomial diarrhea should be considered or are considered, and we recommend to use Lactobacillus rhamnosus GG at least 10 raised to power 9, so billion unit, and the strength of recommendation is very strong. Quality of evidence is very moderate. The same about Lactobacillus reuteri, that we should be using with antibiotic, so that we should be using it when the child is hospitalized to prevent the nosocomial diarrhea. But there is a catch. So 5 out of these 7 trials which suggested or which shown that this is beneficial are pharma sponsored. What is the role of probiotic in pediatric allergies, particularly food allergies, atopic dermatitis, eczema, allergic rhinitis, or asthma? So what is your opinion, or what is your thought process about evidence of use of probiotic in 0 to 2 years old child? Is it a strong evidence in preventing atopic dermatitis, allergy, or asthma? Is there a strong evidence in preventing in high-risk infants, or still the data is uncertain? What do you think? This is the question for our thinking. So the data says there is no benefit of using probiotic in pregnancy or infancy in prevention of eczema, atopic dermatitis, food allergies, or asthma as on today. So there are plenty of meta-analysis on this front in 2020, 2022, and all of them showed there is not a clear evidence or very low evidence for prevention of eczema or atopic dermatitis. What is the role of probiotic in functional GI disorders like infant colic or functional abdominal pain or irritable bowel syndrome or infantile regurgitation or reflux or constipation? So clearly, we have plenty of studies for Lactobacillus reuteri in infantile colic. All of them are, these are the studies which are quoted, are randomized controlled trials. They are used for 21 days. They have not been followed up very well. And it is inconclusive in treatment of infantile colic, both in the breastfed children and formula fed children. But saying so, there is one beautiful study published in JAMA by Indrio Group. And what they have done, they have used the probiotic rotary from birth till 90 days. And they have shown that at 1 month, the lactobacillus rotary group has a lesser colic of 45 minutes as compared to 96 minutes in placebo group, which is clearly significant. And the same outcome remained the same at 3 months post after the birth of the child. So the colic has been 37 minutes as against to 70 minutes. And the secondary outcome they have looked like, has there any decrease in the pediatric visits, emergency department visit, and that has clearly shown benefit. But let's see what other studies will show in the future. What is the role of probiotic in irritable bowel syndrome or functional abdominal syndrome pain? So there have been studies on lactobacillus GG, VSL, bifidobacter, and this is very good study from Gottlieb, VSL3. What they have done, they have given the sachet to one group for 6 weeks, then not given for 2 weeks, and then reverse the group. And that has shown mild benefit, but the quality of evidence is very weak. So at present, the author feel that we should not recommend for irritable bowel syndrome. So with this knowledge of evidence, what we have currently from the European group, American group, and the studies which are published from the Asian countries, particularly some of the studies from India. So it is very clearly hype for IBS, food allergy, persistent diarrhea, Clostridium difficile, no role. A low or poor quality evidence to support in acute infectious diarrhea, lactobacillus GG and Saccharomyces boulardii and Bacillus clausi. Infantile colic, if you are starting from day 0 and giving for 90 days, probably it is going to reduce the colic, but not when the colic started and you give them. That data is showing the poor results. And definitely there is a role in prevention of the NAC in preterm. That data is good. And their reduction of 5% of mortality, reduction of 15% of gut-associated infection is quite a huge number. Definite role in antibiotic therapy prevention for when you are preventing C. difficile infection, when you are using antibiotic, particularly when we are sick in the hospitalizing these children, we should be using them. That is my personal choice. Pouchitis, VSL3 has definite role, and there are the other things are not yet clear. Thank you. I hope we have cleared some doubts, and if there are any questions, I would be very happy to answer them.
Hello.
Yes, sir.
Hello. Am I audible?
Yes, sir.
Hello.
Yes, sir. You are audible.
Sir, you are audible.
Thank you, sir, for the wonderful presentation and for enlightenment regarding the probiotics used to treat the dysbiosis. I hope whatever you told us today will definitely help your practicing pediatrician to prescribe the probiotics rationally from tomorrow onwards.
Thank you.
Over to you,
Thank
Stuti,
you, sir.
ma'am. Hello.
Hello.
I guess there are
Yes.
no questions, so we can wrap up.
Okay, thank you.
Okay, doctor. Thank you so much.